Acute coronary syndrome, the spectrum of unstable angina, non-STEMI and STEMI, is the greatest threat to coronary artery disease patients, resulting in very high in hospital and subsequent mortality for the next 1 year. This syndrome should not be missed. There should be no misdiagnosis. Early diagnosis is very important. Aggressive and optimal medical management and early invasive procedures are required in this high subset of population to give good outcomes and avoid mortality. Patients with rest chest pain of more than 10 minutes duration, patients with increasing severity of pre-existent angina, or patients with new onset of severe angina probably have an acute coronary syndrome. Acute coronary syndrome is a spectrum of disease starting from unstable angina, non-STEMI or ST elevation myocardial infarction. This is one of the highest occurring threats in coronary artery disease, which carries a very high in-hospital mortality of nearly 5 to 10%. Not only this, the subsequent mortality over the next 1 year can be as high as 30% if left untreated. This syndrome calls for immediate presentation to the emergency department on the patient side and early diagnosis, avoidance of missed diagnosis, initiation of aggressive and optimal medical treatment very early, and these patients will benefit from an early intervention by ways of looking at the coronary anatomy through an invasive coronary angiogram as early as 2 to 24 hours after the incident, and fixing the blocks by either a balloon angioplasty or if there is diffuse triple vessel disease along with severe left ventricular dysfunction. These patients may need a coronary artery bypass surgery. These patients, when attended promptly and in the correct fashion, can have excellent outcomes. Otherwise, they can have a very bad outcome. Any patient with an acute onset of chest pain must present to the emergency department by calling an ambulance as early as possible within the first 30 minutes, and this will result in time saved, and the muscle of the heart will be saved and patient will have excellent outcomes. If time is delayed, then there can be loss of heart muscle, resulting in permanent damage and loss of function to the heart with crippling symptoms in the overall long run, and also may result in death of this patient if not attended promptly. Overall, in the Western countries, the time delay between the approach of the patient from the onset of chest pain is in general less than 30 minutes, whereas in our country, in most of these studies, it has shown the time delay can be as much as 3 to 4 hours, and shortening this time will result in a lot of benefit to the patient and his outcomes. Also, calling first the emergency ambulance instead of going on a private transport will also result in better outcomes for the patient.
For the coming 29th of this month, we are all celebrating the World Heart Day, and being the leader of treatment of the heart diseases in this country, Apollo Hospitals definitely would like to send a message to the public. The only thing we would like to impress upon the public that once you get operated after the heart surgery, it's very important to have a regular follow-up and get a rehabilitation done. Many people unfortunately forgets the fact that after surgery everything is set right and they don't even come for follow-up. My only message to those people and the public at large that please do undergo cardiac rehab, to do the physiotherapy and all exercises regularly so that you don't get affected once again. Apollo Hospital has been always the leader in all the medical endeavors, not only in this country and not only in SARC but all over the world, and our popularity has really spread all across the world over the last 3.5 decades. And specifically as a cardiac surgeon, it is my endeavor to see that we treat the billion hearts in this country with a healthy heart. As we all know that cardiac surgery, cardiac diseases, specifically the coronary artery disease, is so massive in this country and so undertreated, in the sense that the number of doctors, the number of hospitals specializing in this particular thing is so less, matching to the population, that we have a very large things to complete. And in particular for the bypass surgery with total arterial conduits, which everybody knows is for the longer duration. This is our endeavor to give all the patients, whenever it is feasible, to give a total arterial conduits, particularly for the bypass surgeries, patients requiring. And more patients are coming at a younger age, and that is very unfortunate for India. And as we all know that Indian subcontinent has been popularized in the sense that it has become the diabetic capital of the world, and therefore the cardiac diseases are also in the increase, and they are affecting the population at the lower age group than what it used to be. Now even in the third and fourth decades, in the early third and fourth decades, the patients are getting affected by cardiac disease. Our endeavor has always been to treat the people of this country, which was not affordable for many of them in the past to go abroad and get treated, and this hospital has been all throughout here in this country to provide the same treatment, or even more in some cases, than what is available abroad.
I am Dr. Karthikeyan, cardiologist and electrophysiologist. Many of you may not be aware that what is the electrophysiology division. This is a subdivision of cardiology which deals cardiac electrical abnormality. You are all aware that heart beats 50 to 100 beats per minute. If there is any abnormality in these heartbeats, say it started beating more than 150 per minute, or it started beating less than 50 per minute, so the patient feels some symptoms, the form of giddiness, palpitation, breathing difficulty, loss of consciousness. So we deal these patients with those who have the electrical problem which controls the heartbeat. So especially when the patients comes with a very fast heartbeat, say by symptoms like palpitation and giddiness, and rapidly starts and then stops rapidly. So these patients, we do procedure called electrophysiology study, which like angiogram, we do insert catheters inside the heart and then record the electrical system or the electrical activities of the heart and find out what is the abnormality in the electrical activity. Say some people are born with some extra electrical connections, some people are having developed because of the hypertension and diabetes. Over the period of time they develop some abnormal electrical activities in the heart, which give rise to rapid heartbeat and symptoms like palpitation and breathlessness. Once you are able to identify the abnormality by electrophysiology study, we can cure this problem by doing radiofrequency ablation. Radiofrequency is a source of energy, is alternating current delivered in the tissues, which unnecessarily produces extra electrical impulses. By doing that, we can cure the problems. So many of these palpitation patients go home without taking any medications lifelong, so they can avoid taking lifelong medical therapy. This is the advantage of doing these procedures. These procedures are done as a daycare procedures. Patients can get admitted and get it done, and next day they will get discharged and they go home without any medications. They need not take any rest also. It is a pinhole procedure done in a 2 hours duration of time, and then patients lifelong need not take any medical therapy. So the electrophysiology division deals the abnormal cardiac electrical problems which controls the heartbeat. So heart is beating because of electrical impulse originates in the heart. If there is any abnormality in the electrical impulse generation, say somebody is having a less generation of electrical impulses, they come with a low heartbeat. When there is a low heartbeat, they develop the symptoms like giddiness, breathing difficulty, and loss of consciousness. So once we know that problem by simple ECGs or monitoring like 24 hours monitoring or extended monitoring for 1 week or long-term monitoring, by even we can monitor up to 3 years. Once you know that heartbeat is the problem, say especially low heartbeat, we do what we call pacemaker implantation, which is an external electrical source implanted under the skin from the left pectoral region, which maintains the heartbeat at whatever rate we set in. So by doing that, we can avoid life-threatening problems as well as loss of consciousness. And patients, though sometimes after the heart attack, their pumping will be very low. Even after bypass surgeries or angioplasties, their pumping sometimes will be less than 35%. They continue to have breathing difficulty and breathlessness. So those patients, to avoid sudden cardiac death, we do a device called external implantable defibrillator, what you call AICD, automatic implantable cardioverter defibrillator. This device, like a pacemaker, implanted from the left shoulder region below the collarbone, which continuously monitors the heartbeat. At any point of time, patient develops life-threatening cardiac heartbeat, fast heartbeat, which can take away their life. This device immediately within few seconds identifies and then delivers a shock and makes it normal. So by doing that, patient's life will be saved, and it's preventing sudden cardiac arrest. And then this is a life-saving procedure. It should be considered for the patient, those who continue to have ejection fraction less than 35% after the bypass surgery or angioplasty. And also patients, those who have the poor pumping function like ejection fraction less than 35%, also they continue to have breathing difficulty, repeatedly getting admitted in the hospital with the breathing difficulties. Those selected patients, we do procedure called biventricular pacing, which to augment the pumping function of the heart. So by doing that of the triple chamber pacemaker, we can boost the pumping function of the heart, so that patient will not get admitted again and again with the breathing difficulty, with heart failure related symptoms. Those who are not able to walk for few meters, able to walk few kilometers after these procedures. These are the technical advancement. Nowadays we do more procedures with MRI-compatible. Those days, if you do any of these device implantation like pacemakers or ICDs, patient cannot undergo MRI scan. Nowadays we do regularly MRI-compatible scan devices, so that any requirement for in the body for MRI scan, patient can undergo safely MRI scan irrespective of the device which they receive. Especially MRI-compatible device, if they receive, they can safely undergo MRI scan.
My name is Dr. Madan Kumar. I am going to talk for ALICE 2016. I came to Chennai in 2011 after getting trained in end-stage heart and lung diseases in Harefield Hospital, one of the world-renowned heart and lung transplant center. My aim while coming here is to bring the healthcare, what is there in the developed countries, to our India. And let me talk about something about end-stage heart and lung diseases. End-stage heart, lung and diseases means the heart or the lungs have been damaged to the extent where medications were not possible. Only surgical interventions will be of some help. So those kind of patients are termed as end-stage heart and lung disease patients. And these patients can be offered heart transplantation or lung transplantation or heart and lung transplantation or mechanical circulatory system like in the form of left ventricular assist devices. So when I came from London here to Chennai, I saw a completely different set of patients here in contrast with the abroad patients. For example, when I am in my clinic in London, a patient came to my clinic and said that he is not able to jog properly. That's what his presenting symptoms was. Then we evaluated him and found to have dilated cardiomyopathy. He was put on follow-up, and then he will be followed up every 6 months and will be advising appropriate medicines. But here, a patient who will not be able to go to the toilet also will say that he is all right and he is able to do the things properly. In which case he will be already in end-stage heart disease affecting his lungs, kidney and the liver. So the presentation is very late in India. For that, I am not saying that we need to intervene all the patients who are early in their heart and lung diseases. And there are clear-cut scoring system which says when the patient needs heart and lung transplantation. That is called as window period. In the course of the end-stage heart disease patient's history, there is a phase called as too early for transplant, a transplant window where they have to be offered for transplant, and then too sick for transplantation. And transplantation is not like placing a new machine and then getting the patient to work. Always there is a risk between the infection and rejection in the post-op period. So as far as possible, we should give back their own heart. If that is not possible, then we have to go for this heart and lung transplantation. And my advice will be to consult your doctors early and then make the diagnosis and then get appropriate advices and visit a transplant center also to get properly evaluated and then take care of your health in a better way. Thank you.
Greetings. I'm here on behalf of ALICE, which is the acronym for Apollo Leadership and Innovations in Cardiac Endeavours 2016. And on behalf of Dr. Sundar, Dr. Madan and myself, Dr. Paul Ramesh, I'm here to talk to you about the advances that we have made at Apollo hospitals with regard to the management of patients with end-stage heart and lung disease. When we started way back in 2006, the Apollo main hospital in Greams Road has a tradition of doing cardiac transplantation that goes back to 1994. The three of us, that is Dr. Sundar, Dr. Madan and myself, have renewed the heart and lung failure management program in surgery since the early 2000s. From about 2006, we have constructed with great care a very robust interdisciplinary team that looks after the care of this group of patients who have especially unique features in our country. One of the main features that we have discovered over the years is the late presentation of patients with both heart and lung disease, which invariably leads to a concomitant failure of other organs, whether it is the lung in the case of end-stage heart disease, or the heart in the case of end-stage lung disease, or other organs such as the liver and the kidney. These patients are also extremely malnourished, immobile, dependent on oxygen, have anxiety, depression, they are not very compliant with medication, and a host of other related problems both for themselves as well as their relatives. So it was immediately apparent to us that just introducing a straightforward surgical service providing transplantation and mechanical circulatory support such as LVAD was not sufficient in itself. The vast majority of patients required both early triage and a pathway, a clinical pathway that led to further medical management, optimization of their condition, consideration for left ventricular assist devices or transplantation as the case may be. At our hospital, we as a team are able to provide both heart transplantation, lung transplantation, whether it is single or double lung transplantation, and combined heart and lung transplantation. We also have done combined heart, lung and kidney transplantation as well as a combined heart liver transplantation. Whether patients would benefit from this or not was part of the assessment, but the other part of the assessment was how could the other streams of medicine, for example, pulmonology, cardiology, endocrinology, GI, infectious diseases, psychiatry and other allied services such as heart failure nurse and physiotherapy help the rehabilitation of these patients. We now can boast of a program that can provide a comprehensive 360-degree coverage for patients who suffer from both end-stage heart and lung diseases, including the acute management of these conditions with the use of ECMO or short-term left ventricular assist devices in patients who present with cardiogenic shock or acute respiratory failure, in patients with H1N1 and poisonings in whom there is both combined heart and lung failure, as well as in patients who may require chronic therapy for these conditions, as well as patients who do not qualify for routine therapy and may be patients for palliative care. And on behalf of the Department of Cardiothoracic Surgery and the Department of Heart and Lung Transplantation, I would like to make a few points clear to people who may want to know how to prevent heart disease. Being a surgeon, it is very important that we communicate the end stage of this disease to those who might be in the early stages or who may not have yet developed the disease, so that the most important part of heart disease is its prevention. In general, in our country, we have a high burden of diabetes, hypertension, people who are smokers, as well as very unhealthy food habits and lifestyles brought on by living in cities or in being with modern employment structures such as IT offices and leading a sedentary lifestyle. So all of this predisposes to heart disease. Now, heart disease can be in the form of disorders that can prevent enough blood going to the muscle of the heart, such as coronary artery disease, which is one of the commonest conditions, and this can be worsened by diabetes and hypertension, but could also include diseases that happen in children because of congenital anomalies that are present from birth, or diseases of the valves, as well as diseases of the heart muscle. So the problem with the heart is that it's a very central and important organ that pumps blood to all parts of the body, and if you have a heart that is failing, in time all other organs will also fail, rendering the patient both susceptible to early death but also to severe disability that stops them from having a productive life. So in addition to preventive measures, it is important that you have appropriate lifestyle interventions such as the time to play in the fresh air, time to get exercise, eat healthy food, interact with friends, have a rounded life which decreases the stress on the arteries and the heart and prevents either development or progression of this disease. I hope that the usual measures such as diet and exercise, in addition to more important lifestyle measures, form a part of your everyday life so that you can prevent or at least decrease the burden of heart disease in our country. Thank you.
Hello, I am Dr. Rajeshwari Naik, consultant cardiologist at Apollo Hospital, Chennai. Every year on 29th of September, we observe World Heart Day. The main aim is to improve heart health by improving public awareness. Healthy heart of a person basically reflects the healthy health of the family, which in turn reflects the health of the society and country. My message to everyone on this day will be, take care of your health and take care of your heart. Prevention is always better than cure. Exercise daily, at least 30 to 40 minutes of walk or any kind of exercise at least 5 to 6 days a week. Eat healthy food. Include lots of fruits and vegetables in your diet. Avoid red meat. Stop smoking. Avoid alcohol. Take care of your stress, both family and professional stress. We see lots of young people in the age group of 20s and 30s, 40s coming with a heart attack, and main reason or risk factor behind this is stress. So taking care of stress is very important. You may either take up some hobbies or relaxation exercise in the form of meditation, yoga. Everyone above the age of 40 should have a health checkup done every year. If you have a strong family history of stroke or heart problem, you should start yearly heart checkup as early as 20 or 30 years. You may consult your physician or cardiologist who will advise you how often or how frequently you should undergo yearly checkup. One special message to all women, you have to take care of your health. Usually you give importance to your spouse or parents or children's health and needs. You keep your symptoms and problems with yourself. Many women come to us very late with symptoms. By the time they come to us, they would have been having more severe form of disease in the form of heart attack or heart failure, poor pumping of the heart, uncontrolled blood pressure leading on to stroke or kidney problem. I suggest all women or advise all women, take care of your health by exercising, eating well and taking care of your stress, and also equally giving importance to your yearly health checkup. Earlier we used to believe that coronary artery disease or a heart problem or stroke is not common in women. It is not true anymore. Actually we see young people, young women as early as 30s and 40s coming with high blood pressure and stroke and heart failure. Many a time it is underreported, many a time it is not reported by the women or the lady. The symptoms she ignore or hide so that she will have enough time to take care of the family and other needs of the family. When a lady comes with a heart attack, she is at more risk for complication than a man coming at the same age with a heart attack. Hence the importance for women to report their symptoms very early and come to the doctor instead of ignoring chest pain and breathing difficulty and coming late and having more risky procedures with less benefit. Better to come early and get treated. We see women coming very late with symptoms. They ignore their chest pain and breathing difficulty thinking that it is not important because they are busy with some other. In our clinical practice, we usually see women not reporting their symptoms at all, or they come very late with chest pain or breathing difficulty. Many times they ignore their symptoms so that they get enough time for their family. They are worried when they come to a hospital, they will be treated or hospitalized and they will not have enough time to take care of the children and other members of the family. My advice to all women will be, whenever you feel any chest pain or breathing difficulty, come to your doctor or go to your physician early stage, so that we can prevent you getting more complications in the form of heart attack, heart failure, stroke and kidney problems. It is always easy for us to treat you all at an early stage than when you come very late with complications. What happens when you come late is the benefit of the procedure or any surgical procedure or any interventional procedure, the benefit will be less and risk will be more. Same, if you come early, you will have much more benefit with a very meager or very small risk involved in the procedure or surgery. A smiling face, a peaceful heart, a healthy heart, taking care of your health by regular exercise, eating healthy, avoiding smoking and alcohol. This is my advice to all of you to have a healthy and long life. Stress is a very major risk factor for both heart problem and stroke. We see nowadays people coming at the age of 20s and 30s with high blood pressure and heart attack and also stroke. It is very sad to see these people as young as 20s coming. We usually see people at the age of 60s and 70s coming with heart attack and stroke. We used to see in 60s, 70s in the past, but not anymore. We are seeing younger and younger people coming with more and more heart problem and stroke. This main reason for this is stress. Stress both at home and professional life. It is very important that we take care of our stress. There are different ways and means we can take care of our stress. Best is to take up some mental relaxation exercises. Please give equal importance to mental relaxation exercises like physical exercises. At least 30 to 40 minutes of mental relaxation in the form of meditation, yoga, music, some hobbies in the form of gardening, painting, drawing, anything that I need not suggest some hobbies to you. Whatever gives you mental relaxation, whatever you like should be done so the mind is very calm and the stress can be avoided. And one more point is, when you have stress either in the home or at office place, best is to discuss it out with a good friend and relieve the stress than keeping it in the mind and increasing the stress to a level, blowing up the high blood pressure to so much so that the patient develops a heart attack and stroke. The main aim is to prevent that kind of stress leading on to a major catastrophe in the form of heart attack and stroke. So 30 minutes of physical exercise, at least 30 minutes of mental relaxation, sleeping 6 to 8 hours every day, eating healthy, avoiding smoking and alcohol, and yearly health checkup should do wonders to have a long healthy life.
I would like to stress upon the importance of primary angioplasty in case of acute heart attacks. This is what is called primary PCI, primary coronary interventions. When a patient gets heart attack, when he gets chest pain, he goes to the nearest doctor. So the doctor should refer this patient to a angioplasty capable center as early as possible. Earlier you do angioplasty, better are the results, better are the long-term outcomes and quality of life. When the patient reaches Apollo emergency, immediately our ER doctors will take care of, do an ECG, do the blood test, get the patient prepared, and cardiology team is alerted. The patient is wheeled into the cath lab or cardiac catheterization laboratory as early as possible. Immediately we do the angiogram, confirm the blocked vessel, remove the block and put a stent and restore the blood flow. This is what is called primary angioplasty. The time between the patient arrival to emergency and the balloon dilatation should be less than 90 minutes. That is called door to balloon time. Lesser the door to balloon time, better are the results. In our hospital, we are trying to do as early as possible, even less than 40 minutes. It is essential for the referring doctors to know the importance of this primary angioplasty, and without any delay, these patients should be referred to centers where there is primary angioplasty capabilities there. Fortunately, the team of doctors are available 24/7, and we have got about 4 cardiac catheterization laboratories. Anytime patient comes, he need not have to wait, immediately we can wheel him into the theatre. The availability of catheterization laboratories and experienced, skilled team is also very important in this endeavor. When once you do angioplasty, the myocardial damage can be minimized, pumping can be, the damage to the heart pumping is minimized, so the quality of life is much better and patient will have a better future. So always I strongly recommend for patients of heart attack, primary angioplasty.
Coronary angioplasty and stenting is one of the most common procedures done throughout the world to treat coronary disease and stenotic narrowing of the coronary blood vessels. Intracoronary imaging has revolutionized the precision of angioplasty, which means that with the intracoronary imaging, a small miniaturized probe is inserted into the coronary artery, which has a 3-dimensional structure where we analyze the coronary artery, analyze the nature of the plaque, understand the vessel size, and plan accordingly. So one of the most common intravascular imaging is intravascular ultrasound. Intravascular ultrasound is similar to ultrasound what we use for a scan purpose, where these probes have a small probe as a miniaturized transducer, which transmits ultrasound waves, and the blood vessels are scanned, and the information on the plaque are stored in the machine, and we analyze it, and depending upon the appropriate stent selection and preparation of the vessel is made. So after stenting, the procedure, intravascular ultrasound procedure, can be repeated and made sure that stent is appropriately placed and the vessel is well opened. The other method of intracoronary imaging which is recently available is optical coherence tomography, or OCT. OCT has very high resolution. The resolution of OCT is almost like an electron microscopy. Unlike ultrasound, which is more penetration, OCT gives a magnified view of the superficial structures within the coronary vessels. One can understand the extent of thrombus, the nature of the plaque, and whether it is a soft plaque or a hard plaque, and plan appropriate pre-dilatation and stent placement, and get the best possible result with precision. So OCT is now used very often in the difficult or challenging procedures, or when we have a suboptimal outcome, to analyze the stents and the bioabsorbable scaffold, which is again a new form of therapy where the stents disappear over time, and OCT helps to evaluate these bioabsorbable scaffold. Now moving on to coronary physiology, there is a procedure known as FFR, or fractional flow reserve, which has very high scientific evidence with the level of evidence 1A. So these patients who have a borderline or intermediate blocks are often assessed using pressure wire with FFR. So it has a clear-cut cutoff value. If the FFR value is above 0.8, these patients need not be treated and left with medical management, and we have a lot of evidence-based studies for this. And if the FFR is less than 0.8, then these patients require revascularization with either stenting or CABG surgery. So by using this method, one can be very sure whether to treat it or to leave it. So unnecessary stenting will not be done. At the same time, important block which can give rise to problems later can be found out and can be treated appropriately using stents. FFR is a relatively simple procedure where a small guide wire with a pressure transducer tip is passed through the coronary vessels beyond the block, and the pressure assessed before and after the block, by which we can assess the significance of the block. So this has got huge evidence, and now it is routinely done to assess those patients where we have intermediate lesions, whether to revascularize or not. The bioabsorbable scaffolds is one of the latest type of stent available. We were the first to deploy the bioabsorbable scaffold in India in December of 2012. These are scaffolds which can be compared to like polymers which dissolve over time. The coronary artery blocks are normally treated by stents made with metal, and these metals remain forever within the coronary artery. Unlike these metallic stents, the new revolution or the fourth revolution of interventional cardiology, which is bioabsorbable scaffold, it dissolves over time. There are a number of scaffolds currently available in the market. The most commonly used and the first available scaffold was absorb scaffold, which is commercially used, and we have done several patients who have been treated with absorb, and these bioabsorbable scaffold dissolve over 2 to 3 years time. It gets completely dissolved. These blocks only require a scaffolding for a first initial period of time, and then they don't require. And once these scaffolds dissolve, the artery is remodeled into a normal artery, and even sometimes we get a very bigger lumen, and these patients do well. The data for bioabsorbable scaffolds are very encouraging, and now the current data has been shown to have been non-inferior with the currently available best-in-class regulating stents. There are several advantages to when we use the bioabsorbable scaffold. One, these patients can be subjected to bypass surgery at the same site and at a later period whenever it is required. Since these bioabsorbable scaffolds disappear, the surgeons can easily graft in those areas of the blood vessels when these scaffolds disappear. And also there are several other advantages like the vasomotor tone, which means the relaxation and constriction function of the blood vessel is restored. With the metallic stents jail the blood vessels, and as a result these blood vessels lose their vasomotor tone and are unable to vasodilate or vasoconstrict. Whereas in patients who receive the bioabsorbable scaffold, the scaffolds disappear and the vasomotor tone returns to normal. So the patients have a vasoconstrictor and vasodilatory function, which is very important physiological regulatory mechanism for coronary arteries. Not only that, there are other advantages when we use a bioabsorbable scaffold. The patient can be subjected to an MRI immediately after the procedure, which cannot be done when we use a metallic stent. And the evaluation of the stented coronary arteries can be better when we use a CT scan when these bioabsorbable scaffolds are used. Unlike when the metallic stents, the CT scan can give blurring artifacts and may be difficult to interpret within the stent when we use a metallic stent. So these are the several advantages of bioabsorbable scaffold, and particularly in young patients, we don't have to give long-term dual antiplatelet drugs, and it's very attractive in young patients. Innovation in Apollo, transcatheter aortic valve replacement. Aortic stenosis is a condition where one of the heart valves is narrowed, and hence the heart finds it difficult to pump blood. Aortic stenosis commonly occurs in the elderly. Normally, the aortic valve has got 3 cusps, and over the years, due to wear and tear, the valve gets thickened and deformed and gets narrowed. If the valve is either bicuspid or unequal shape by birth, then the patients present early, even they develop aortic stenosis in their 40s or even earlier. Generally, for tricuspid valves, the aortic stenosis occurs in the 70s and 80s and even sometimes in the 90s. So the elderly patients often who have other comorbid conditions like lung disease and kidney disease and who have already had a bypass surgery often find it difficult when the aortic stenosis develops. In India, almost about 14.5 lakh patients have aortic stenosis. And of that, about 4.5 lakh patients are left untreated and they develop symptoms over time. And the best possible treatment for patients who have aortic stenosis is replacement of aortic valve. Conventionally, it was done by open surgery. Today, we have a new and innovative method of replacing the aortic valve by transcatheter method, which is known as TAVR or TAVI, TAVR or TAVI, which is transcatheter aortic valve replacement. So in patients who have very high risk or high or intermediate risk for open surgery, TAVR or TAVR is the preferred method of aortic valve replacement. In this method, the patient is given under local anesthesia very often, treated with a catheter-based method where a valve is threaded through a small hole, just like an angioplasty stenting. The catheter is through the hole in the thigh, it is taken to the heart, and then the valve is deployed. Unlike the conventional stenting, the transcatheter aortic valve replacement catheters are very big and bulky and hence need a big artery to take these devices. These devices can be implanted by percutaneous method, so no cut down or surgery is required, and the valve replaced in 1 or 2 hours. The patient's symptoms dramatically improve after the valve replacement, and they are often discharged in days 2 or day 3. This is a unique and innovative method. Though it started in 2002 by Professor Alain Cribier in France, it took some time to come to India, and in Apollo it was the first procedure was done in November 2015, and since then it's been a very pioneer in transcatheter aortic valve replacement. A patient with aortic stenosis, when he presents with symptoms, they are evaluated and put into several tests including ECG, echocardiogram and the coronary CT as well as a CT of the aortic valve. The CT scan of the aortic valve is the most important investigation where a complete analysis of the aortic valve is done and the feasibility as well as the appropriate valve size is calculated and the procedure is planned. So the patient generally is a very short hospital stay, and then they are followed up as an outpatient, and they do clinically do very well. The two most commonly used valves are the Evolute core valve and the Edwards sapien valve. We have a large experience with the Evolute core valve, and Edwards sapien valve will be shortly launched in India, and Apollo will be one of the 4 centers in India which will start the Edwards program. TAVR or transcatheter aortic valve replacement indeed is a boon to elderly patients with aortic stenosis and given a second lease of life to these patients. We have operated as elderly as 91 years who have gone through this procedure with much ease, and they do very well after this procedure.
Good morning. I am Dr. Sundar. I am a heart and lung surgeon and a heart and lung transplant surgeon in Apollo Hospitals, Chennai. We are having a big regional meet, a cardiological and cardiac surgical meet, ALICE 2016, which is an Apollo Leadership and Innovations in Cardiac Endeavours. We have the facility of providing complete care for patients with heart and lung diseases. This includes both neonatal, pediatric and adult patients, and the entire gamut of treatments are offered in this surgery. Transplants, heart and lung transplant, multi-organ transplants, implantation of artificial heart for heart failure, and bypass surgery, valve surgery, aortic surgery is all being done. The entire gamut of chest operations for lung cancer, smoking related diseases, emphysema are offered. Lung transplantation is also being offered. So with the approaching World Heart Day, my advice would be to try and take steps to prevent heart disease. India is fast becoming a country where there is going to be an increased incidence of diabetes and heart disease, what we call the non-communicable diseases. And if we take steps to prevent these, that would go a long way. My points to make on the event of World Heart Day is stay healthy by watching your diet, make sure you have enough exercise, adjust your lifestyle, stop or avoid smoking altogether. Wishing you all a happy and a healthy life.
Hello, I am Dr. Vijay Chandra Reddy, Senior Consultant and Interventional Cardiologist from Apollo Main Hospitals, Chennai. Sedentary lifestyle is one of the common risk factors for a host of diseases, especially cardiovascular disorders, heart attacks, strokes, as well as cancers, diabetes, hypertension and dyslipidemia. What is ideal is to do moderate intensity aerobic exercise of at least 30 minutes duration, at least 5 days a week. 4 forms of exercise components are very important. One is the cardio, the one which usually we stress upon, that is the aerobic exercise activity like good walks or jogging or a bit of running, cycling, swimming. The second aspect, which is also equally important, is muscle strengthening. As you all know, beyond the age of 30, the muscle proteins get lost every day, and some amount of muscle strengthening as per the health status is recommended. The third facet of exercise is flexibility, which is very important as well, and yoga or tai chi or simple pilates or any exercise regime which involves a little bit of flexibility is welcome as well. The fourth most important component, more so in the elderly, is the component of balance. Without this, fractures and falls are more likely. So a comprehensive exercise prescription would involve all these four components of exercise. On the eve of World Heart Day, the theme being Power Your Lives, I would recommend everyone to power our lives through a healthy heart, through good activity prescription. Angioplasty and stenting of coronary arteries is a well-proven medical procedure, and in acute ST elevation MI, of course, primary angioplasty and stenting is the evidence-based gold standard therapy. Even in this group of ST elevation MI and the non-ST elevation MI with cardiogenic shock, what is considered as the most sinister of the cardiac presentations, still with these technologies we will be able to save more patients than ever before. For example, with the conservative medical line of management, the ability to save the cardiogenic shock patients is almost 10 to 20% only. With such a high mortality rates, anything would have been primary angioplasty and stenting, even in this setting of cardiogenic shock, can save more than 60 to 70% of such cases. Of course, use of mechanical ventilation, aortic balloon pump supports, intra-LV pump devices, aggressive intensive care with the appropriate medical management adds to the success of these intervened patients in cardiogenic shock. We also see a subgroup of patients who have cardiac arrest outside the hospital but then are resuscitated, and some of them will be shifted to a hospital on ambuing and ventilation. Even in this gravest subgroup of patients, we call it as a compassionate PCI, because many a time we won't even be sure whether their cerebral status is good or not. What the protocol, what we follow is first to take them to the lab, do the coronary angioplasty procedure with appropriate techniques and technology and save them, and then subject them to hypothermic protocols and save as many of them as possible. In our series in the last 7 years of about 40 such patients, the results have been very encouraging. We were able to save more than 80 to 82% of these patients. There is a subgroup of patients who are octo and nonagenarians, above 80 years of age, very frail, elderly with borderline renal functions, and who come with acute ST elevation MI, some of them in cardiogenic shock. Even in this subgroup of patients, angioplasty and stenting would be the most favorable treatment option to deliver good outcomes. At the other end of the age spectrum, the very young MIs, which our country is more known for, those in the 25 to 40 years age group, the commonest pathophysiology seems to be the plaque erosion or endothelial denudation with thrombus occluding the coronary artery. Here we need not put in a stent in majority of cases. We use the technology of invasive aspiration thrombectomy with pharmacological glycoprotein 2B3A receptor therapy, and many of them can get away with simple non-stenting practices.